Please, yes. I'd love to welcome ISABEL Mestres, Chief Executive Officer of City Cancer Challenge, or CCAN, and Joe Romanelli, the President and Human Health International of MSD. Thank you so much for joining us. These conversations tonight have been terrific, and I'm really excited to dive into the next one. Our Her Power program is covering a lot of ground, from opposition movements to sustainability, and now we're going to talk a little bit more about health, and specifically about women. This session is entitled Thriving Cities and Healthy Women, and it's really focused on public-private partnerships for cancer care. As many of us in this room know, women are often at the center of health in communities, the health of our families, but somewhat paradoxically, women often have among the worst health outcomes, especially as it relates to cancer, and in particular, and in low and middle income countries. And that is what we're here to talk about. Why is that the case, and what can be done about it? And I have two experts with me coming from distinct but complementary perspectives on this issue. Not only what is the problem, but most importantly, what concretely is being done about it and what needs to be done to scale, strengthening health systems for better outcomes for women and reduced cancer rates overall. So, ISABEL, I'd like to start with you first. You have spent the better part of the last few decades working on these issues. And first question to you is, with respect to women, where are women falling through the gaps? When you're on the front lines in cities around the world, what are you seeing with respect to women and cancer rates?
Okay. Thank you. Thank you so much for having us. So, first of all, a few facts to understand why women are falling into the tracks of the health systems. The women account 75% of the workforce in the health system. And when we talk about the caregivers, it's 90%. We sustained healthcare. But 25% of the decision makers are men. So only 25% of the women are in decision-making positions. And if we go to low resource settings, we go to 5%. So the systems are designed by men for men. So that's the first challenge, the workforce. The women are not in leadership positions, so they're making decisions that are not adapted to women's needs. The other thing is patriarchal cultural things. We're seeing that there's a lot of gender bias that is affecting women. And we realized there was a Lancet Commission a few years ago where actually they've given evidence that because you are a woman, being the gender aspect of woman, you actually have worse outcomes. We are later in diagnostics than men. We have more access barriers. We are referred badly. So when we go with a headache, oh, you have a headache. We're not referred properly. So the women are having late diagnostics in cancer. Even in Denmark, I've just read in the McKinsey report, 2.5 years more than men in delays. So there is a lot of barriers. And what we talk about the solutions, then we cannot address this as a disease only. We have to address from a whole comprehensive approach. Women not as patients, but what are women in society? What are the time issues that women have? What are the barriers they have to get to the doctor? Why they're late diagnosed? How we get the workforce into leadership positions if we want to actually address women's health. So it's not only a medical issue.
That's really stark. And you make very clear this is an issue everywhere. For you to just cite that statistic from McKinsey that, in Denmark, women are accessing care 2 years later than men. And imagine then the impacts around the world in low resource settings. Years, and then when you're talking about cancer, the degree to which that can metastasize and impact health outcomes if you don't have that early access to treatment, it's just remarkable, and I think really underscores that this is an issue that everyone needs to be addressing. Joe, I'd like to turn to you, and from MSD's perspective, MSD has really galvanized and gotten behind at women's health and with WEF and in partnership with WEF. And so from your perspective and MSD's, why focus on women and women's cancer? How are you seeing women falling through the cracks from a health systems perspective?
Yeah, so thank you, and it's great to be here. So I would say as one of the largest biopharmaceutical companies in the world, we've been grounded on two principles. One is how many people can we reach and how much help can we give them? So generally we follow the science. So if you take a key and a lock as an exemplar, the lock is the biology. We've had 2 billion years of evolution. So we're looking for a key that can unlock a biological process. And that could happen years ago from a small molecule to create an enzymatic reaction to then maybe prevent something or eliminate something, to all the way up to today where we're using cell and gene therapy to try to unlock disease and really turn back the clock on disease. Now, when we go after that research, we don't say, hey, we want to be here, we want to be there, we want to be in men's health, or we want to be in women's health. We let this science guide us. Now, what's been great about us as a company is that we have this, I would say, mission of we try never to forget that medicine is for the people, profits will follow. And that sent us to the right places. So one great exemplar of that is cervical cancer. So many years ago, we developed a vaccine that would potentially prevent cervical cancer. It's our HPV vaccine. Now, when we think about cervical cancer around the world, we've had this vaccine since 2006. There's still 1,000 women per day dying of cervical cancer. And, shame on us if we don't do something to eliminate that. And what's even harder to accept, at times, many years, we didn't have ample vaccine. So we had to really distribute vaccines according to which health systems were ready for it. And not all health systems were ready for it. We got so good at producing the vaccine that we now had a surplus. And even last year, we went out to many countries and said, not only do we have enough vaccine, we'll give it to you for free. Do you know how many countries took us up on that? 0. And to me, there's a problem in the system, and I think something that this extraordinary leader can help solve is how do we build the right ecosystem that really ensures that all parts of the healthcare community are connected. Because what happens is you go to a country and someone has an idea, but there aren't oncologists. There isn't a pap smearing program, right? There's nowhere to go to get a pap smear. There's not enough OBGYNs in the community. There aren't enough oncologists if you're diagnosed with cervical cancer. And then you probably, to the earlier point, don't have a treatment. Now, one area that I think has worked really well, and we cited breast cancer. If you look at breast cancer today, if you're diagnosed early, almost 100% survival rate at 5 years. But if you're not diagnosed, if you're diagnosed late, that drops down to 25%. And so I think what we've tried to do in working in partnerships, public-private partnerships, is find leaders who are trying to, just going back to that key and lock, unlock the system, because we know we have resources, those keys, to then help that system. And I think when we look at women's health, I think we're making steady progress. I'll give you one great example. We bought a company 2 years ago, and that company produces what's called an antibody drug conjugate, and that's directed against TROP2. This largely impacts women's cancers, endometrial cancer, for example. We know that we'll be first in class, and so we're already thinking through what would need to be true in these markets, that we have the right enterprise go-to-market processes, that in a place like Indonesia where they don't have enough oncologists, we can make sure we make that available to Indonesian women. And so that's something we have to start very early, because you have to have the right clinical trials, you have to have the right manufacturing processes, and you have to have the right regulatory framework to be able to launch those products in those markets. So I think having these types of partnerships can help us, especially in those low middle income markets, to be able to do that.
Thank you for that. And I think that's a great segue to understanding the how in terms of breaking down those silos and really forging the kinds of partnerships that are able to affect change in dynamic and different systems and settings. So, we talk about Denmark, we talk about Indonesia. Each one of those locations is so distinct and so different. And so understanding those localities, what may be common but also unique within each setting, is absolutely important to breaking down those silos and strengthening local systems. And so, Isabel, I'd like to turn to you. City Cancer Challenge is doing and has been doing incredible work at local levels, understanding what are those dynamics and what really needs to happen to connect those dots. And so I'm curious if you could talk a little bit more about that work to understand each one of those landscapes, and then we'll come back around to, Joe, what you were just talking about, how those kinds of partnerships are really instrumental and absolutely vital to ensuring better health outcomes at a local level, and then to be able to scale.
Excellent. So I'm happy to share the model, because actually, if you're not working on oncology, but you're working on other disease, it's going to be very, very useful. So actually, 9 years ago, we were launched here in Davos. And SICAN was created because, exactly to Joe's point, if you live where you live or who you are defines if you survive or not of cancer. So, 75% of women with breast cancer die in low-resource settings, while 25% die in high-income countries. So it's a knowledge transfer. There is the treatment, there is the innovation, but it's not reaching the patients. So we had a question is, how? How do we support low and middle-income countries to actually upgrade their system to benefit for all this great innovation? How do we support governments to translate plans into action? Because we were seeing a lot of national cancer control plan, a lot of great deals at the UN, but very little actually getting implemented. So back then, oncology was it's a complex disease, and it was so focused at the national level, and we were seeing a lot of intervention like screening. But screening in those contexts just give you some facts that there's some potential people with cancer, but those people, those women are going to have access to a diagnostic. They're going to have to pay out of pocket for the treatment. So those interventions didn't change the system. So we wanted to actually come with a solution that was transformative, that tackled the system in a whole. And that was like, wow, everybody thinking like, how on earth are you going to do that? And that's where we decided to go to cities. And don't think about a city like the political dimension. Don't start thinking of your mayor necessarily. Think of the city, that the city is the minimum viable product of a system. It's a national system in a reality. You can touch it. You bring all the different hospitals. You can see how the patient navigates from primary to secondary to tertiary. You can see how the academia brings the workforce. You can see how the data is collected. In a city, things happen. It's touchable, it creates. So working at the city level, we bring all the stakeholders that normally they don't work together. So we work national government, regional government, local government, directors of public, private hospital, the academia, the reimbursement system, insurance, the private sector, civil society, work together and start understanding where are the gaps in the system. So we are able to collect real-world data because it's tangible. Country level, it's policy. So at the city, we generate the data, and we work with the local stakeholders to come with contextualized solutions. We bring the international community, the global experts like WHO or the Atomic Energy Agency or ASCO, to bring the evidence. But that evidence is based on high-income country. So we work with locals to translate that evidence into contextualized evidence of those contexts. So we're currently working in 16 cities. The model works. We're seeing already reduction on time from diagnostic to treatment, decrease on abandonment rates. We're starting to see outcomes, and we're now ready to scale. And we're very excited to work with Merck, with MSD, because this is not and we'll talk about that, this is not a one single actor challenge. We need to work all together, and it's so bright, the future. It's looking good. We know how. We just now need to get all together to make it happen.
Okay, so we know how, and you explained that very well, and the work you're doing is absolutely incredible to harness that data and learn from it and see how it can be replicated. But in terms of working together, it's hard, right? Working with Heather.
It's fascinating.
It's fascinating. Yes, you're right. It's fascinating. Very well put. And And it takes time. And so I'm curious, Joe, from your perspective and in your work, when you're thinking about forging those partnerships, how do you go about it? And how are you thinking about it in terms of bringing together the local officials, leaders like Isabel at CCAN? How are you thinking about forging those relationships and making sure that everyone is bringing to bear their distinct but complementary perspectives and skills?
Yeah, so I'll use a metaphor going back to the HPV vaccine. One of the interesting things that I've observed in this role over the past 3.5 years, prior to this, I was leading our business in China. And it was a lot easier to get women to line up at vaccination centers who are, in their 30s to 40s, even up to 45, to be vaccinated because they want to take control of their health. And that was happening in low and middle income countries. It's a lot harder to do that here in Europe. We're making steady progress, but to convince someone who's a mid-adult woman who's been married to then go out and be vaccinated, it's a very different thesis around what knowledge do they need? How do you activate that consumer in the same way that you've done it in places like Thailand, in the Philippines, in China? It's interesting. People will travel miles, hours to be vaccinated. They pay out of their pocket, and their annual income is a fraction of what it is here in Europe. So what I've found in working with leaders in this world is they're much more entrepreneurial. They're willing to get together. They're willing to drop egos and develop solutions. When we look at places like India, we have the leading oncology product in the world. The government was taking its time thinking through, should we reimburse this? Because we think we're here in Europe, we think about reimbursement. So we worked with a few local partners to figure out, well, how could we drive access out of pocket, but use third parties to determine how people could pay and what could they afford based on their annual salary. And so trying to create these bespoke systems for each individual in a private market. And that kind of entrepreneurial spirit, I think, thrives in the emerging markets and low middle income countries. So I think number one, the mindset is right. Now, sometimes you talked about this earlier, people tend to play in their boxes. So you just need someone that can kind of string them together and help them understand that the value chain, the process, how it's going to work and how they fit into that process. So I think mindset is critical. Number two is resourcing. These things don't happen because we wish them to happen. It takes time, energy, and resources. And I'm not just talking about financial resources. I tell my children, you don't become a champion by showing up on Saturday. You become a champion by showing up 4 hours in the gym every day. That's how you become a champion on Saturday. It's the same thing. These things don't happen because we show up at Davos. Beautiful place. They happen because somewhere in Phnom Penh, someone's grinding away to try to figure out how to connect this screening center with this diagnostic center with this hospital. And that's driving the results, but no one sees that. Yeah. And so how do you continue to support those folks in working with organizations like that? And then lastly is it's up to us to then feed that with new inventions. Our job is invention. By the way, we fail at it 99% of the time. But we have to kind of keep aspiring to invent new things that are going to treat some of the most undruggable diseases that we've found. I mean, we don't understand enough about the human biology, and that's why hopefully AI, we talked about this earlier, will help us. But I think to me, those three things are extremely important because we don't have a modality here. A lot of this work is great. So you've screened someone, you've diagnosed them, but there's nothing there to treat them with. And so I think all those things have to happen in concert.
I'm going to pick up on that and your point about resourcing and how important it is to bring to bear resources and capacity, especially in a resource-constrained environment. And so when you're thinking about the fascinating process of partnerships, I'm curious, Isabel, how you're thinking about that resourcing and in very resource-constrained environments, low-income settings, low-resource settings, how are you thinking about mobilizing those partners that have knowledge to bring to bear, financial resources to bring to bear? You're sitting at the helm of this organization and you have to pick your partners so that there is that complementarity. How are you thinking about that?
So, first of all, it's not about bringing, there is no money to go to take, and GDPs are what it is. So it's about how we can have an efficient system and what are the best interventions, because sometimes we bring the different hospitals and they all say, no, I need a PET scan. No, I want the PET scan. And I'm like, well, because data showing that in the private hospital, the PET scan is available and underutilized. So let's think together how we leverage that PET scan. And this is part of the importance of generating the data. So we bring the data and we come with the efficiencies for the system. And then once we have what is important for the local stakeholders, then we mobilize the community. And this is important because traditionally there's a lot of donor-driven interventions. City Cancer Challenge is locally led. We don't respond to donors, and that is a huge challenge, let me tell you, from a fundraising perspective. A lot of pharma, technology companies, digital companies come to us and say, oh, we want to test this AI, or we want to do this thing on lung cancer. And I'm like, well, it's not a priority for the local stakeholders. And that is hard. But we're so committed on strengthening the system and responding to the local system that then our role is to bring the right partners that have the right mindset, that they're looking for the long term, not for the short intervention that is going to give you the nice, shiny numbers for your brochure, but it's not going to make any transformation at the local system. So the first thing is, thank you. Thank you. I appreciate it because it's very hard to maintain this model. But I have to say I'm very lucky with our partnership with Merck and a few other companies that understand it. How do we do it? Being very transparent and say, okay, you want this intervention, let me tell you, at the end of the year, you're going to have X woman screen and that's it. Yeah. But it's not going to happen. So trust, transparency, be very open. The more open and the more you prove that this is the good for the long term, that's going to be transformative, I think the more credible you are. You're not going to get the quick money, but you're going to get, hopefully, the right partners around the table.
Yes.
By the way, just a public service announcement. So MSD is US Merck. I don't want to get in trouble here in Europe. We're called MSD outside of the US.
So what is the right one? I always get confused.
In the US, it's Merck. Outside the US, it's MSD.
So we say MSD.
Okay. Thank you for that. And your focus on health system strengthening for the long term, because in a lot of cases, as you said, there's no money. And so where can there be greater systems alignment and efficiencies gained and through these partnerships?
Can I add something? Sorry.
Yeah, please.
There is money, but there is no data on where to invest that money. So there is a lot of money and willingness to invest, but most of the money is going to private hospitals where it's more but it's not bringing equity. So the big challenge we need to know is generate data and evidence for unbankable deals to attract the money. So I want to say, I want to take that back. There is money, but there is no data to bring that money.
And I think there needs to be a case made to those who have those resources on where to most efficiently and effectively invest. So on that note, and we're running out of time, we're out of time, but Joe, want to close with you and get your perspective on that exactly. Speaking to the audience at the World Economic Forum and thinking about health system strengthening for the long term, where do those investments need to be targeted and why is it worth it if your focus is on near-term return?
Yeah, so as I said, I'll just give you an exemplar from us as a company. So back in the 1980s, river blindness in sub-Saharan Africa and Latin America was, debilitating, and not just personally, but economically. We developed something called ivermectin, Mectizam, and we've been donating that product for the past 30 years. And in many cases, many parts of the world, we've been able to eliminate river blindness. But that started because of leadership. None of this happens without leaders. No matter how much money you have, you throw all the money at it you want. Nothing will happen if you don't have. We had a leader, a CEO at the time, who saw this as an epidemic, even went to governments, and they said, not interested. And so he pledged that not only would MSD develop, manufacture this product, but we'll give it for free in perpetuity. And we've been doing that. In fact, we reached 250 million patients last year with our Mectizan program. So I think it takes leadership. I think leaders, find a way to get things done. They plow through. They make sure that if there isn't resourcing in one area, they're going to go to another area. If they need people in one area, they'll go to another area. But they stay committed and they see things to the long term. So just like as a company, we can't take shortcuts. Same thing with CCAN. They can't take shortcuts. They have to look at the long term. They can't just, you're in 15 cities today. You don't want to be in 30 tomorrow. You have to be very strategic about where you're going to invest your time, your resources, and what type of outcomes are you going to drive. So I think all of us need to think through this as a long-term opportunity. And what I hope is that one day these low middle income markets train the higher income markets. Because I think what we're going to learn here may drive, because no country is one market. I grew up in Philadelphia. We didn't have a lot of money, right? You went to a public clinic. You can go out here. I live in Switzerland. There are places where people need help in Switzerland. There are places where people need help in Poland. So there are many other parts of the world, not just where we talked about in Cambodia, that could use help. So I think we prove it there, and then we can spread it elsewhere.
Yeah. Very well put. Thank you both. So much more to discuss, but I appreciate your time today, the work you're doing, and the threads of team science and also leadership for the long term. You're both demonstrating that very, very well. Thank you both. Joe Romanelli, MSD, and Isabel Mestres from CCAN.